Rick, Sherry, thank you so much for having me back. I always enjoyed it and seeing a lot of friendly and a couple not so friendly faces out there. But I am going to be talking about choosing wisely. And first of all, before I get into that, how many here, just for my knowledge and for yours, how many are physicians here? A lot. Any nursing? Any administrators? Well, we got a mix, mainly physician, clinical staff. Well, choosing wisely, right? The game changer, the savior, the best thing since sliced bread for medicine, right? How many of you can even name 5 choosing wisely? The 10 that ACEP's put out, how many can name 5? How many can you name 10? I'm doing the talk and I'm not sure I could name all 10 off my head. But I'm going to talk a little bit about why we're doing choosing wisely, why this is important, and what are some of the things out there that we need to do to make it more useful for medicine. Why are we doing choosing wisely? Why? I'll just throw that out there. Why are we doing choosing wisely? Because frankly, we fought it for the first 3 years in emergency medicine. We were the last specialty to come in. And I was president of ACEP during that. And so I had to take a lot of hits on that. But why are we doing this? What's that? Waste. Save money. Money. I see everybody going, money, money. It's all about the money. And you know what? You're probably right. It's about the money. It's also about doing the right thing. It's also about maybe talking with our patients, heaven forbid. And so there's some really good things. But because it's a great idea, does that mean it's great in practice? Well, I don't think we know yet. And I'm going to go over some of the issues about this. So you're right. Choosing wisely is really, really about the money. Most of the things we are doing is really about the money. Value. Value equals quality divided by cost plus service excellence. All right? That cost in the denominator, that's a big one. You can improve quality, you can improve service excellence. You still got to do it at lower cost. So how are we going to do that? Improving quality, improving the patient experience costs money usually, not decreasing costs. So we're going to have to get more efficient in what we're doing, and that's what the choosing wisely is. But here, you've seen all these, by per capita, per percent of GDP, the U.S. is way off the map, all right, compared to any other. And then they'll talk about quality, and you measure quality, but quality, again, the U.S. is not towards the top of quality in terms of life expectancy, in terms of premature death, infant mortality, morbidity of industrialized nations. Now, there's some literature coming out showing that what are the differences between morbidity between the U.S. and the rest of the world? Is it in cardiac deaths now? No, it's due to drugs, trauma, and guns. The majority of difference now is coming down to those 3 things, and that's why you're seeing some administrations looking at these areas to go after in terms of trying to decrease costs. But whatever measure you're looking at, the U.S. is not great, and it's expensive. All right? So this is a great study. This was in 2007. PricewaterhouseCoopers they were hired to look at waste in the system. And they identified $1.2 trillion of waste in the U.S. healthcare system. So you start over on that left side, all right, behavioral. People are eating too much, they're smoking, they're not exercising, they're drinking. But this is America. It's not their fault, it's somebody else's fault. Right? We can't hold our patients accountable, so let's just get rid of that. All right? So operational, 2.1 to 2.2, I know that doesn't show up tremendously well, but is on inefficient systems for credentialing and all the inefficient paperwork. How many of you have signed recently with a new group and new insurance plans? All right? Yeah. Was your stack this big, or this big? Yeah. All right. That's inefficient. So you go into the primary care specialties, how many staff people have to be for one physician in a primary care office? Remember, there used to be one nurse, one doc, they would go. Now, how many people do you need? Between 3 and 4. All right, it's about 3.4 to 3.6, somewhere in there. I mean, you have to get insurance, make sure insurance will pay, make sure you are going to be getting reimbursed. You got to collect all this information, pre-approval. It is a mess. You know, rehiring people, retention is a big deal. But that second column, the second one, which is clinical, is where, you know, we're going to be looking at. And these are readmissions. So readmissions, defensive medicine is $210 billion. So readmissions, again, all the not taking care of diabetes, all those things that, oh, hey, we can let the doctors and hospitals take care of that because, you know, we don't want the insurance companies to worry too much. And, you know, God forbid the patient, you know, would have to stop smoking. So let's go after the doctors and hospitals, all right? And let's make sure that, you know, we're not doing defensive medicine. We're, you know, making sure they're managing diabetes. A lot of things that are falling on doctors, and that's that middle column, which is about $300 billion. And that's where we're putting a lot of effort in. Now, defensive medicine. What is defensive medicine? Defensive medicine is what? Ordering tests when you know it's probably not necessary, but you're worried about getting sued. And, or having other problems, or perhaps just missing something. You don't want to miss something. You know, it depends on your risk adverseness. But that's a big area, and that's where I think the choosing wisely sort of fits in all of this. So there's 3 goals of the Choosing Wisely campaign. They wanted to help physicians and patients engage in conversations about the appropriate use of medical tests and procedures. Again, great goal, right? Can't complain about that goal. Promote wise choices by clinicians in order to improve health outcomes. Provide patient-centered care that avoids unnecessary and even harmful interventions. And again, in theory, wow, that's like motherhood and apple pie, right? I mean, we want to do the right thing. We want to harm our patients. We don't want to do waste. And then reduce the rapidly expanding costs of our nation's healthcare system. And again, a lot of pressures put on the hospitals and clinicians for their responsibility to do this. So then, again, great goals, right? ACEP should participate in this. And we had a lot of discussions about this. I mean, it does resonate with physicians that it's supposed to consist of respectful conversations with your patients to make informed decisions. That's, you know, if they know what the Choosing Wisely is, and if you know what the Choosing Wisely is, and it doesn't contradict their Google search that they did before they came in. Framed unnecessary care as waste. All right, that's a good way to put it. Unnecessary should be waste. It should be waste to the system. It really should be harm. We should actually get that unnecessary care could be harmful to the patient. And then professional values are motivators. They want to, you know, we as physicians and as nursing and as healthcare providers, we do want to provide the best care. I mean, that's why most of us went into medicine. So they're appealing to professional values to do the best thing for our patients, to provide more cost-efficient and reduce harmful care. And then they wanted to use the physician leadership of the specialty societies. So they went to the specialty societies one by one to get them to agree to provide lists. Basically, do not do lists. You should not do this. All right? And again, it allows communication about unnecessary care. Well, ACEP did not totally embrace this. There were some of you in this room that were probably dead set against this. And then there were some of you in the room that said, we as emergency medicine should do this. And, you know, I understood both sides. I also met with the American Board of Internal Medicine Foundation which really set this up. And again, I think they set this up with really great intentions. I don't think they thought through the whole process, meaning that this was, number one, going to be much bigger than they ever expected. And then how are we going to really know if it works? How are we going to get people to do this? Very important. So we developed 3 work groups, and all 3 said no, we shouldn't participate. All right? That was about a year and a half. And our issues were several. Reimbursement. We were concerned that if it said, I should not get a CAT scan for low-risk head trauma, that doesn't meet the nexus criteria, then I won't, if I order that, I won't get, or the hospital won't get reimbursed for that. There was some real concern about that. In fact, we actually had some Medicare lawyers telling us, yeah, we'll probably use these for reimbursement. So that's a concern. Maybe it's a large concern, but how many of you have ever had a patient where you tell them the nexus criteria? I mean, I had one recently, a woman, she actually worked at Blue Cross Blue Shield, not that I'm supposed to name anything, but she worked at one of the Blues, and she fell at work, didn't lose consciousness, and she didn't meet any criteria. And I tried to explain that to her, and she wanted a CT. And the reason she wanted a CT was her grandfather fell and died of a head bleed. Well, he's probably 80 and he was on Coumadin, but that didn't matter. It was her, so you don't fight these, you get them. But there are reasons sometimes why. So reimbursement was an issue. What's the other big one? Liability, right? We are concerned that if we use these, that they could be potentially used against you. In fact, when you look at practice guidelines are used against physicians more than 4 in lawsuits, about 3 to 1, the studies will show. And again, that doesn't mean that we shouldn't do it, but these are issues that just weren't addressed. The nature of EM practice. How many of you have, they sent, the primary care physician sent them into your ED for that MRI of the spine at 8 o'clock on a Saturday evening. I can tell you that happens just about every shift I work. All right, and then patient satisfaction. We're the Burger King mentality. I want it my way, and I want it now, or I'm going to mark you down lower. I mean, that's a concern. And again, it focuses on not the choosing wisely says do not do. But maybe we should be focusing a different, what should we be doing to provide high quality care? So these are all issues, but it still went to the council and the council voted. And frankly, we didn't want to be the only specialty sticking out. Finally, the surgeons joined in and we were like the last specialty to join in. So we actually did a very good process. I give talks to the medical students and I talk about choosing wisely. I say, well, what would be the first step you would do in developing topics? Even my medical students get this. Go ask your membership, right? So we at ACEP, got 19,000 suggestions from members of what should be in a choosing wisely list. I mean, emergency physicians aren't shy at telling people, what we shouldn't, what they shouldn't be coming in and asking for. So we went out and asked, then we formed work groups, we narrowed those down, we did literature searches to see, did they actually reduce care? Was there clinical evidence to show that it was effective? And could it potentially reduce cost? And then we put it together as a series of voting, and we came up with the first 5. And these are them. It's basically not getting a head CT for low risk, head injury, avoiding indwelling catheters and those that don't need it, don't delay engaging palliative and hospice care for patients that may need it. Now they didn't like this one because it's not a do not do. We said, we actually put it in the positive, like you should be consulting palliative care. And they wanted us to put do not delay. And so we had to put that. Avoid antibiotics in uncomplicated skin infections, and avoid instituting an IV when oral IV therapy could be helpful. So those are our first 5. About a year and a half later, we put out another 5. So avoid CT in patients with syncope without significant trauma. Avoid CT angio with a low PERC score. Avoid lumbar spine imaging, unless they have high risk or red flags for low back pain. Avoid prescribing antibiotics in the emergency department for uncomplicated sinusitis. And avoid ordering CT of the abdomen, pelvis, and otherwise young, healthy patients, ED patients less than 50, with known history of kidney stone, urolithiasis, presenting with symptoms consistent with uncomplicated renal colic. What does that mean? I'm not sure exactly. I live in the stone belt, so we see 15 kidney stones every shift. And most of them are in pain, sick, so I'm not sure exactly what these mean, but these are a start, okay? This is a start. Every other specialty started this. So how many of you use all of these? One person. One person uses all of them. We're going to audit you. No, I think you can put these into your EMRs now. It makes it easier to put these rules in there, but again, there's still a lot of interpretation. And again, in patient factors, none of these really account patient factors. The patient whose grandfather died. It doesn't include, if you have a homeless person or somebody who just doesn't have access to care. Practice guidelines are meant as guidelines. But it's still important to put these out there. I think, if we can have these as solid evidence to talk with our patients, to talk with our physicians, perhaps we might lower the cost of care. All right? So let's look at, now that we've got all these out there and all the other specialties, there's 70-some specialties that are put out now. Most are 10. Some are putting their 15th, their next 5. What does the literature say about this? Well, there was a study in the New England Journal of Medicine 2014 that looked at the distributions of services targeted by the Choosing Wisely lists. And what do you think? So out of imaging, lab, testing, procedures, what do you think the number 1 was? Well, the blue there is imaging. The yellow is testing. All right? So what we found is very little procedures were identified, okay? Ortho didn't say, well, you don't need a hip replacement if you can go through physical therapy. You don't need that knee replacement. A lot of these cardiology about, there was a few now that have come out about angiography and other things, but for the most part, very little procedures were identified. It was mainly testing, it was mainly imaging, and of course, specialties identified waste and other specialty. And which specialty probably got hit more than any? Radiology got hit by the most, I won't deny that. But then emergency medicine also got hit pretty hard by some other specialties, like them telling us what we should be doing. The other more philosophical questions are, can we expect more patients, or most patients, to question their healthcare providers? We do have more and more now, I think. I think the younger generation they're on the phone constantly and looking up stuff, and they may be able to question more, but for the most part, older people rarely question a physician. And so can we really expect, where the bulk of these dollars may be saved, our patients are you able to have really conversations with them? Sometimes patients and physicians may not agree on what constitutes low value. Again, none of these guidelines take in the values of patients. And again, patients' values differ at different ages, right? Somebody, 70 years old may want just a couple of really good years of good health, and be happy with that and not have any more disability. When you're younger, you may accept more disability to live longer. And those are things that, again, most practice guidelines, most guidelines like this just can't handle. It did deal with the supply, the demand side of medicine, not the supply. We've got a lot of supply out there and doing hip replacements and procedures. But are these procedures really necessary in all these patients? If you really want to start looking at the cost of medicine, that's what we need to get to. And again, it didn't look at liability. And there's still a lot of concern out there about liability. And I'm going to show you 2 quick studies. So this is one of the latest studies. This came out in either late October or early November of 2015 in the Journal of American Medical Association Internal Medicine Journal. And this was using an Anthem database, Anthem the insurer database. They had over 7 million visits over 4 years, and they looked at quarterly, seeing with the implementation of the choosing wisely, will it change behavior? And what you can see is up here, and looking at all 7 metrics, they didn't change really at all. Here is for low back pain, getting x-rays, wide variability. Now, getting imaging for head CT, or for headache, actually did go down. This is one of the few that actually went down. Here's antibiotics for acute sinusitis. Again, you see the up and down nature of that. That was not any different. So right now, out of those 3, sinusitis and back x-rays and head CTs went down, the other 2 did not. You look at here, cardiac imaging did go down, but NSAIDs for certain conditions where you shouldn't, and screening for HPV in women less than 30 actually went up. So 2 went down, imaging for headache and imaging, cardiac imaging. 2 went up, HPV screening and NSAIDs. The rest didn't change. And this again was over a 4-year period looking at a very large database. So we're still not really seeing a large decrease in cost or utilization by this. Well, why is that? Well, I mean, we'll have to think about that. I'll get into that. Here's just a recent survey again from November 2015. They asked 4,000 physicians, do you think the choosing wisely are going to lead to more lawsuits? 37% said yes, 24% said no, the rest were unsure. So again, these aren't widely accepted yet as things that we should be using. All right, so now I really want to scare you. If I haven't scared you yet, I want to scare you now. All right? British Medical Journal, one of the largest journals in the world, published an article. This was again November. So all these literature is just starting to come out on the choosing wisely. They looked at a state of Florida, the Florida Healthcare Agency database. So over 28 million visits over 7 years, and I'm sorry, it was 200 million visits over 7 years. And they did by specialty. And that they found down here that, and it's maybe hard to see that, but it says physician with a malpractice claim and what they spent versus a physician without a malpractice claim and what they spent, and then the p-value. And if you spend more, you get sued less. Well, that's a little scary. It's shown even in quartiles here. By specialty, you go down to the bottom here. If you're really efficient, oh, I can't get out of here, sorry. If you're really efficient and don't spend much money, you have a 1.9% odds ratio of getting sued. If you spend a lot of money, you're in the the highest quintile, you have a 0.4 odds ratio. And it goes down by every quintile. So I don't know what that says about American health care, but at least we're still not where we need to be in terms of dealing with this issue. Does spending more money constitute to the patient that we're doing more for them? And so hence they're less likely to sue. Maybe they don't understand the choosing wisely yet as well. So we have a ways to go before these are really going to make an impact.
So what is the future of choosing wisely? I think you have to have accountability for the results. It's great that we put all these choosing wisely. Now we have 10, there's 700 and some that are out there. But now we've got to look at accountability. Is this really what our patients want? And is this going to save money? Procedures clearly need to be on there. We've got to start focusing on some of the bigger ticket items. Everybody doesn't need their knee replacement or their hip replacement and other things. We don't have to recreate this. The National Institute of Clinical Effectiveness, which is, the British version of their National Health Services. Now it is a socialized. They actually have 800 do not do lists. We could use that information, try to help synthesize. I'm not sure, again, we want to move to socialized medicine, but we've got to do some more things here in order to reduce costs. Again, focusing on harmful care. If you tell your patient this is harmful care versus wasteful care, harmful care they don't want. Wasteful care, they think that's probably something that's just can be spread out there. So getting another CT scan, or what I have to do is head to toe CT scan for every trauma patient that comes in, maybe that's harmful. Maybe that's going to cause cancers down the road, and we'll see that, but we've got to start having those discussions. Using these in quality metrics is one way that this will be more implemented. So if we start having to measure this, which will probably come down the line at some point, we will start using these more. If it's linked to maintenance of certification, so we always do maintenance certification, and if maybe we have to look at one choosing wisely and how you're doing with that. That may be something that's coming down the line to, again, try to implement these more. It has to be, cannot be linked to reimbursement. If it gets linked to reimbursement, you will kill the choosing wisely. And so we really need to fight all efforts on that. Education is going to be important. We have in medicine, medicine has never been perfect, and it never will be perfect. But we've got to resist the impulse to rule out all possibilities and really focus on true positives. That's going to require some education with our patients. Align doctors on what constitutes harmful care and better explanations of chance findings. We need to do some more education with our patients. And, again, maybe it's not always just the doctor, but, our team surrounding those healthcare providers have to do some better education. And we got to educate the public on the choosing wisely to a much greater extent. And then liability. I think, my own personal opinion, I fought ACEP for years on our EMTALA-related care, as the end-all, be-all for liability reform. I don't think that changes anybody's behavior if you give them EMTALA liability. But if you give them safe harbors for using practice guidelines or for using choosing wisely, meaning I make a good faith effort. Now, people don't like the word choosing safe harbor. That's fine. Some sort of liability protection. If I make a good faith effort to use these, I should be protected. Even if they find that rare 1 in a million brain tumor in somebody with a normal neurological exam with a little bit of a headache for a week, I shouldn't get sued for that because I did my best faith effort to use it. That's where we should be looking at. Other specialties are starting to look at that, but emergency medicine, I think, in particular, if you want to change behavior, you want to lower costs, then you've got to give some safe harbor for liability. I really think it will lead to expanded use. So with that, I think there's a lot of promise. I know I was a little sarcastic up here about the choosing wise. I think there's a lot of promise here. I think there are still a lot of issues we need to work through. It is about cutting costs, but it is about reducing harmful care as well and providing the best care to our patients. And despite studies, I hope we see in the future that we can practice cost-effective care, not get sued, and still have great outcomes. I don't think we're there yet. This is an initial step. We need to do a lot more work.